I'm David Steensma from the Dana-Farber Cancer Institute and Harvard Medical School in Boston, Massachusetts. I'm here at the Key Insights into Hematologic Malignancies at the Great Debates and Updates in Hematologic Malignancies in New York. The segments of the program that I moderated were those on chronic lymphocytic leukemia, the not-so-benign hematology, non-malignant hematology, the myeloid disorders, including both chronic myeloid leukemias, myelodysplastic syndromes, and myeloproliferative neoplasms, and a session on acute lymphoblastic leukemia. Today in the chronic lymphocytic leukemia section, we heard a debate between Rick Furman and Matt Davids about where some of the newer agents fit in CLL. Now that ibrutinib and venetoclax and idelalisib are FDA approved and are seeing increased use in patients with CLL and have in most cases, more favorable safety profile compared to chemoimmunotherapy such as FCR or bendamustine rituximab, should they be moved earlier in the treatment paradigm of patients with CLL? Matt Davids argued that most likely they should, that we're probably going to increasingly see use of ibrutinib in particular as a first-line agent. Rick Furman argued not so fast. We don't have a lot of data to support that yet. Most of the patients who have problems with CLL tend to be the higher risk group, and in the lower risk patients and those with earlier forms of disease, we have not seen a major change in survival with the approval of these new agents. So we'll have to wait for additional data to tell us how to proceed. We also saw an update on hairy cell leukemia from Jay Park from Memorial Sloan Kettering. Jay was involved in the clinical trial of vemurafenib, a BRAF inhibitor, in patients with relapsed and refractory classical hairy cell leukemia. Many patients with hairy cell leukemia of the classical variant do well for many years with cladribine or penostatin, with or without rituximab, but some patients do relapse, and the relapses tend to become more rapid as time goes on. As the patients have received multiple lines of purinucleoside analog-based therapy. Vemurafenib has not been tried in a large number of patients, but we now have clinical experience that shows in those patients who are treated with the drug, the complete response and partial response rate is 100%. Many of these patients have durable responses. And although the drug can be somewhat tough to take for some patients with a lot of arthralgias and myalgias, overall it tends to be tolerable. So where does that fit, given that there are also new CD22 monoclonal antibodies coming along, given that there is more than one BRAF inhibitor that's approved for malignant melanoma? We're not entirely sure, but it certainly is an option for patients with relapsed refractory disease. Finally, Tim Call from the Mayo Clinic, a very experienced clinician with a lot of practical wisdom, talked about some of the adverse events associated with some of the newer agents for CLL. The platelet dysfunction that's seen with ibrutinib is a particular challenge, and for those patients who are undergoing surgical procedures, the ibrutinib ideally should be stopped at least 5 days before the procedure in order to minimize bleeding risk. In addition, Tim spoke about drug-drug interactions with the newer agents and about management of atrial fibrillation in this group. We had an interesting healthcare policy update from Ted Okon from the Community Oncology Alliance. Ted is his background is business, and he spent the last 15 years interacting with politicians and with regulators and with pharmaceutical companies and with nonprofit organizations, patient support organizations, to try to navigate some of the enormous challenges that we face right now in healthcare. There's a lot of uncertainty what's going to happen with the Affordable Care Act. There's a lot of uncertainty what's going to happen with very practical things like co-payment foundations. And so he updated us on some of the uncertainties around that. A lot of partisan politics involved. And Ted tried to present a very neutral and informative view. Then we spoke about myeloid disorders. Mrinal Patnick from the Mayo Clinic talked about chronic myelomonocytic leukemia. This is somewhat of an orphan disease, a difficult and uncommon disease. Mrinal has been quite involved in prognostic modeling in CMML and has defined ASXL1 as a gene that's associated with a particularly poor prognosis for reasons that are really unclear. Then I spoke on management of adverse events associated with tyrosine kinase inhibitor therapy in chronic myeloid leukemia. TKI therapy has completely changed the natural history of CML and has really been an enormous benefit to patients. But of course, they can only benefit if they are taking the drug and if they're tolerating the drug. And so we discuss management of specific adverse events, everything from cardiovascular adverse events to more minor events such as fluid retention and GI upset. Mrinal Patnick then returned to speak about management of CML and pregnancy. We've had some very nice stories where patients were treated for CML, obtained a deep remission, and then were able to go on and have successful pregnancies. It's really a wonderful thing when this happens. However, there are risks for both the pregnant woman and for her male partner if he is the one with CML who's on the TKI. And Mrinal talked about management of that. Interferon is the only drug that's known to be absolutely safe in pregnancy, and so many patients are bridged with alpha interferon through pregnancy if they do need therapy. Some can just be monitored without therapy, but they need to be managed very carefully by a high-risk maternal fetal medicine group and by the hematologist in consultation. In our segment on non-neoplastic hematology, we had 3 presentations. Michael Auerbach from Baltimore, who has the most experience with parenteral iron, spoke about use of some of the newer preparations of IV iron in patients with iron deficiency, including some special populations like pregnant women and those who are traveling to altitude. Michael is really an advocate of greater use of IV iron, and now there are more than 5 different products available in the United States that have a more favorable adverse event profile than many physicians who were trained in the era of high molecular weight iron dextran may remember. Carlos de Castro talked about some of the newer approaches to PNH. Eculizumab, the anti-complement antibody, has changed management of PNH for the better, but there are still patients who experience hemolysis with eculizumab. Clonal evolution is a huge problem, and we need new agents for this condition. So Carlos talked a little bit about oral complement inhibitors that are in development and about some of the other approaches to PNH. Finally, Ken Bauer talked about the difficult challenge of treating the thrombocytopenic patient who needs anticoagulation management. Many times we have patients who develop a thrombosis during cancer therapy, which has caused thrombocytopenia. The most extreme example are those patients with acute leukemia, and it can be very difficult to know how to anticoagulate a patient who's developed a large clot, yet is platelet transfusion dependent. And Ken talked about what we know in that situation, including what utility some of the newer agents, such as direct oral anticoagulates, might be in that situation. Dan D'Angelo from the leukemia program at my institution, Dana-Farber, spoke about newer antibodies for ALL. Almost certainly we will see approval of inotuzumab in 2017, a CD22 antibody drug conjugate, and we recently saw the approval of blinatumomab, a bispecific T-cell enhancer antibody that targets CD19. These and other agents are changing the way that we manage relapse refractory ALL, and they're being moved forward now, and there are studies going on of their use in additional therapy as part of the consolidation for ALL. Dan also talked a little bit about the importance of minimal residual disease monitoring. Then Ruben Mesa from the Mayo Clinic in Arizona spoke about what to do with patients with myelofibrosis for whom ruxolitinib, which is the one drug that is approved for higher risk patients and intermediate patients with myelofibrosis. What happens when that fails the patient? When the spleen regrows, when the patient's cytopenias are such that they can't tolerate the agents. There have been several other JAK2 inhibitors in development, but many of them have run into roadblocks, either with adverse events that were unexpected or not meeting the endpoint of pivotal clinical trials. So Ruben talked about some of the other strategies, including the use of interferon in that setting and some of the newer clinical trial agents such as hedgehog inhibitors and pentraxin analog PRM151. Finally, Rafael Behar and Gail Robaz from UCSD and Cornell Medical Center, respectively, talked about the role of molecular testing in myeloid neoplasia, both in MDS and in AML. We're seeing a lot more use of next-generation sequencing panels for patients, evaluation of patients either with those diagnoses or patients suspected of having those diagnoses. Ben Ebert and I and some of our colleagues define this entity of clonal hematopoiesis of indeterminate potential, or CHIP, and we're trying to figure out where is the borderline between CHIP, meaning mutations that are seen in elderly people without cytopenias who don't really have a disease, and low-risk MDS. It's a very, very difficult line to draw. They also, Raphael and Gail, debated the routine use of molecular testing in patients with myeloid malignancies. Are we putting the cart before the horse by testing in a lot of patients? Well, sometimes we pick up targetable mutations, such as IDH mutations. That's uncommon in MDS, but they're frequent enough in AML that now that targeted agents are available for IDH mutations, that can change management. We also know that these next-generation sequencing tools influence the prognosis of patients, but where exactly should they fit in the evaluation of patients? And how do we interpret these panels? Those are often very challenging tests to interpret. Many hematologists, oncologists trained in an era before routine molecular testing was available, and this is a new skill set. This is an entirely new type of assay and requires both knowledge and experience to be able to use appropriately. So it's really been, I think, a great group of topics that we've been able to cover here at the Great Debates and Updates and Hematologic Malignancies meeting. Things that are really very practical, and we've had a great audience turnout this year, just an audience that's very engaged, asking good questions about how they should treat their patients. And it is such an exciting era right now in hematologic malignancies with new drugs and new assays, and it's just a very exciting time to be part of this field. Thank you for your attention.